we've known for a long time that corticosteroids are useful for the treatment of giant cell arteritis. In this case, we focused on temporal arteritis, which is a frequent, relatively frequent variant that can lead to ischemic complications, for example, loss of vision. The question in this debate was whether the additional use of anti-IL-6 receptor antibodies, Tocilizumab in this case, is beneficial and should even be used from the start. So there is evidence that Tocilizumab is superior. Tocilizumab together with steroids is superior to steroids alone. The question is whether this should be used from the start and whether it is cost effective, considering that it is a monoclonal antibody with a cost. I think in principle, there is good evidence that Tocilizumab works. So if you speak with, depending on the various hospitals, the pathways of the treatment of giant cell arteritis may be led typically by ophthalmology or rheumatology, and then neurology being involved because the patients present with headache, for example. So in somebody over the age of 50 who has a certain type of headache, particularly if there is visual dysfunction, then there is a red flag, an alarm for what is considered essentially a medical emergency because it could lead to visual loss. The impression is, if you speak to colleagues, that when patients are on steroids and Tocilizumab, the professionals are not worried about them because the combination works. There was a phase 2 study published in 2016 in the Lancet, and then followed by a phase 3 clinical trial in 2017, and then an open label extension in 2021 in the New England Journal of Medicine and in Lancet Rheumatology, respectively, showing that the combination is superior in terms of efficacy, but also in terms of reducing the total dose of steroids, so effectively being a good steroid-sparing agent. The disadvantages are the costs and then some risks, or at least theoretical risk. When you use anti-IL-6 receptor antagonists, you lose the usefulness of biomarkers of inflammation, such as ESR and CRP, because the antibody suppresses them completely. So you're not able to use those as biomarker of reactivation. You have to monitor the patients potentially a bit more closely. The other theoretical risk is of an increased risk of infection because of the way the antibody works, but actually in the trials that wasn't the case. The other consideration, of course, is the cost effectiveness. So in the debate, for example, the two debaters emphasized, understandably, the efficacy for the yes and the cost for the no and the potential risks. An interesting approach has been taken in the United Kingdom, where I work also, by the National Institute of Clinical Excellence, NICE, which is very good at looking at cost effectiveness. So what they recommended is that Tocilizumab should be used for relapsing disease or refractory disease. And it should be stopped in any case after a year, so that people then could stay on the steroids but stop the Tocilizumab. And this is a consideration of cost, of course. If you look at the quality-adjusted life years, the cost, NICE is very good at deciding on whether a drug should be used, given that we have finite resources in a certain healthcare system. Interestingly, the debaters were one in the UK and one from the United States, so the healthcare systems, of course, are different. We don't have an insurance system in the UK, whereas they do in the United States. So that you can understand that there might be an emphasis on in the United States speaker for the priority of meeting the patient's needs. So your patient matters, you should meet their needs. On the other hand, in a different healthcare system, you would say we have finite resources, we have to have criteria. We cannot give everything to everyone.